We're going to talk about extensor tendon repairs and protocols. So if it hits the MPs, then you're in zone 5. And if it's proximal to the MPs but distal of the wrist, then you're in zone 6. Okay, so zone 6 is huge. We have someone right now who has cut it looks like he's cut all of them, but he may have only cut these two, but his lacerations extend from his index finger all the way down to his small finger. Okay, we're looking at zone 6 protocol. So we have several different protocols. We have an early active motion protocol that requires an outrigger. So the splint comes volarly, and then it has it's like a pan splint, and it comes like this, and then you're allowed to flex, and then the bands around here with the outrigger pull you back into extension. That is an early active extensor tendon protocol. It's in the Indiana handbooks, it's in all the protocol books. We in Miami, I think I've done it once. But that doctor no longer works here. So I don't think he works here anymore. So you want to know it, right? But it's not as a common protocol that, I see a lot here. If you prefer something that's just a little bit easier but still beneficial, then you can do the extensor tendon repair zone 5 and 6. That's on page 71 of the Indiana protocol book, right? So it tells you that you should be removing the post-op splint 3 to 5 days after. A very common mistake that people, I think that therapists make, that I've seen over the years, is that whatever the doctor's splints come in as, they replicate that in a custom fitted splint, and that is wrong. Wrong. So you have to know your protocol so you know what you should be doing, not just copying what the doctor did. And it's not quote unquote wrong what he did. He needed to do based on whatever his protocol is for post-surgical 3 to 5 days, right? The protocol of the splint is that the wrist should be in 20 degrees of extension. MPs are in 0, and IPs are free. Okay, so IPs are free. It's going to look like a ladder splint. If nothing happened to their thumb, they should be able to move their thumb, and they should be able to move their eyepiece. Okay, they're to wear that for 4 weeks. Now, in the meantime, what are you doing? In the meantime, between the time they come to see you and 4 weeks, you should be able to get full active and passive IP motion. You should be able to get wrist extension. You should be able to, by 2 weeks, have that whole incision healed, cleaned, no open wounds, no eschar, no nothing. You should be doing a ton of scar management, edema massage, so that at 4 weeks, you can start initiating active range of motion at the wrists and digits. Okay, isolated extensor digitorum exercises are emphasized, along with using Velcro strappers to assist with isolating MP joint flexion and extension. So this is a protocol of, this is what they want you to do. They want you to come into MP flexion and IP extension. What can we do to help that? So at 4 weeks, you're allowed to start doing this, okay? At 4 weeks, you're allowed to start to do this, okay? So wrist goes into flexion, you can work on finger extension. Wrist goes into extension, you can work on finger flexion, okay? This is active motion. Now, the splint is continued. The wrist immobilization splint with MP block is continued between exercises and a night. At 6 weeks, you're allowed to start doing passive range of motion exercises. So at 4 weeks, you start active. At 6 weeks, you start passive. It is critical to ensure that any residual extrinsic extensor tightness is resolved at this time. That's really hard. So 4 weeks, you do active range of motion. 6 weeks, you can start doing passive range of motion. And around 7 weeks, you can initiate gentle strengthening. But now that is to say, and usually I get rid of the splint between 4 and 6 weeks. Now, usually with any tendon issues, you have to decide based on tendon excursion whether you're going to advance or slow someone down. So if someone comes into you and they're like this, okay, full wrist extension, MPs, it's already a struggle just to get to neutral wrist or 20 degrees. There's nothing wrong with moving the wrist a little bit, especially if the IPs, you're not stressing the tendon repair. So you have to really think about, how do you stress a tendon repair? So it's an extensor tendon. How are you stressing it? Full flexion and wrist extension. That's how you stress that repair. Now, if you go into extension, is that going to stress the repair? No, it's not. So you can work on IP extension, wrist extension, so that they have that composite. You need to make sure that you work on the IPs so they have no problems with that. Okay? Now, if someone's already behind, you have to think, how do you catch them up? So they already came late. They're a little bit behind. Mm-hmm. They came in really, really stiff, painful, scared. How can you start to catch them up? So you've got to make them feel comfortable that they are they're allowed to move their wrist a little bit, okay? They can move their wrist back. You can encourage somewhat of a tenodesis, right? And you're not pushing. You're just going to let them bring the wrist into flexion, and then they can gently extend, okay? Let them go into a little bit of extension. Their MPs are still going to be straight, right? And you can work on IP. You cannot work on IPs and MPs at the same time. But what can you work on? IPs and MPs, right? So if you start working on some MPs, some active MPs in the clinic, what does that mimic? What protocol? The active motion one, right? So the active motion one allows a certain amount of tendon excursion. So you just allow small arcs of motion. So you block them, say, okay, I'm going to manually block you and I want you to bend all the way down, okay? So how do you get them to do that? How do you get them to do that? You're blocking their IPs and you force MP motion. How do you do that? Are you going to sit there and hold their IPs? You make the little tube splints, okay? Make a little tube split, put it on there, because it's going to force MP motion. Because if they have great IP motion and they're stuck in MP, every time you ask them to bend, they're going to curl in. And they're not going to be able to flex their MPs, okay? Now, someone who's tight in both directions won't do anything. They're like right in the middle. So what do you need to do to encourage one and the other? They should be taught and reminded daily, every day they come, that they need to be doing a ton of hook fisting, all the way open, all the way down. They need to be taught how to block, okay? They need to be taught passive IP extension and passive flexion all the way down, because there's nothing that they can't do with their IPs. They can active, passive, all of it. It should be better within a week. They should have great motion within a week, 2 weeks at the most. By the time you start active motion, their IP should be loosey-goosey, and they're going to have trouble coming into MP flexion because their IPs are so strong, okay? Someone who's really stuck, so the general, protocol, the general school of thinking is, when you're stuck, you need to move faster. You need to progress them faster in their post-op stages. When they are loosey-goosey, that means they don't have enough scar tissue, then you need to slow them down, okay? So someone who's really stuck, like the dude that we have, he's so stuck, you actually could have started some active early, okay? You could have started him at 3 weeks. You could have done a little bit of active plus a little bit of active assisted to help him, but you're already doing a ton of passive here. You gotta start some active or active assisted. Here you can start with the wrist. Just gotta get that wrist moving, because that tendon, the scarring is tight. So you gotta go into full extension, to scrunch it up, right? Do a lot of scar massage, and then to bring him down to stretch him out. So if someone is really scarred down, really tight, you've got to think, I've got to get this guy moving, and I've got to catch him up if he's coming late, okay? What if you have someone who's like super easy? We had someone recently like that. She was done with her extensor tendon protocol of a 1-digit injury in 8 visits. It's usually, a lot more, but she had a cut. She had a zone 5 injury, which essentially follows the same protocol, zone 5. The first day, super tight. Second time she came in, she was like, look, my eyepiece are moving and whatever. And we were seeing her essentially once a week. Twice a week at the beginning, then we went down to once a week for a total of 8 sessions over a month and a half. So the first 4 weeks, when you start active, she was really tight. We did the, what can we do to help you? But the key thing to look for is extension. Can you isolate their extension? Can you wrap them up here and isolate their extension? Okay. The only way to isolate extension, you can either make them hook fist something, and then they're going to extend. This is gravity eliminated. This is against gravity. So we would have her hook fist, and then we had her hook fist, and then we would have her come down and extend. Come down and extend. And then we put her on the plane, and then we would have her extend. This is against gravity. This is to make those extensor tendons pop out. How do we check that we're not overdoing it? Against gravity, opens her fingers, and there's no lag. If you have a lag, you have a problem. All right? If you have a lag, that's a whole nother conversation. If you sort of see a mild one, but it's not too much of a problem, this only applies when it's a 1 tendon injury, right? You have to create a yoke. Okay? You can make a fancy splint, or you can use a pen. I've just created a yoke. And so now I'm going to have them go into extension, into flexion, and then extension. See what happens when they go into extension? They don't go into full extension.